everyone. And like our task forces, they're only as good as the best practices cases, the time and effort that members, and the questions that people ask. But we're thrilled this year to take on a new subject area, social determinants of health. And we've heard the buzz in a lot of different ways and venues. And we're going to try and come up with some best practices on a few aspects of it to share. And we know that these will be interesting. We're not sure who's going to be presenting yet. So if you have ideas, please put them forward. But we know we want to cover the following: the roles of HIEs in sharing and accessing social determinants. Many are getting active, some very successfully, some just dabbling. We're going to look for some good stories there. To categories of data and coding schemes that Z codes, etc., things that can make information catalogable and it can be used for both transactional purposes to help individuals and for analytics purposes, as we're going to hear today. Certainly at least one on the role of telehealth, remote monitoring, and patient-reported data, which are big in general and are changing healthcare, but we want to look at the role of those in interactions with the social determinants to really come up with some things that make a difference. How collaboratives like the many New York State DISRIP PPS collaboratives that we've heard from before and some others, how they are aligning stakeholders to capture and utilize social determinants, because the data by itself doesn't do anything. And I know you'll hear some interesting aspects of this by Dr. V's presentation. And then if we have time, if the year doesn't run away from us, we want to take on something that's a little dicey now, so we'll have to wait till it calms down just a little bit: policy and operational issues surrounding surveillance and behavior associated with social determinants. There's no right or wrong here, but we have to face that reality. So other topics, please submit, send them into Claudia. If you know of folks that could provide a good success story in one of these, please let us know. That's it. I think you can move along, Claudia.
Thanks, Al. So, unlike, as I mentioned, unlike a webinar where all the participants are muted, we are not muted. It's self. You do it yourself on this one, but you can speak up on these calls, and we really do want to hear your questions, and if you have any, just thoughts that you'd like to share. So you can do it up through the chat. You can raise your hand. So please make this as interactive as you'd like. So why don't we go ahead and get started, Dr. Fraunfelter? And I'll be moving the slides.
Thank you so much, Claudia. And I have the good fortune of being home, as many of us are, with my 4 school-age kids at home. So they're quiet for the moment, and we'll hope that continues. So go ahead to the next slide, and I'll just give a little bit of background on Javion and what we are as a company. We're an artificial intelligence company that's relatively old from healthcare AI perspective. We've been around for about 10 years, and we're providing patient-specific insights into risk and what's going to happen to those patients as a result of those drivers of risk, and some of those are social determinant. And then we offer prescriptive insights that are particular to patients. We offer interventions that will help reduce the patient's risk. That's what we do. We're pretty we're pretty strong in healthcare. We're leading the market. We've got representation of about 30 million patients in our database based on our clients. So we're about 10% of the U.S. patient population now in our solution, which is helpful to drive understanding of patients holistically. So what we're doing with COVID, and this has been obviously since it all popped up in the last few weeks, is we're tackling 3 different aspects. The community response is what we're going to focus on with the vulnerability map. We're also providing to our customers patient-specific insights around a list of high-risk patients that combines social determinant data and clinical data. And then what we call an inpatient triage assessment, which is specifically looking at how how to direct patients to the right level of care based upon their acuity and also their prognosis. So there are some complex issues there, but we're focusing today on the vulnerability map, which is using purely socioeconomic data. Now, we've been using data, the socioeconomic data that we purchased for a number of years in the context of the clinical questions for patients. What we've done in the last year is derive insights just driven off of social determinants. And we published in January in the American Journal of Managed Care. We took that approach and the mapping around it, and you can go ahead to the next slide, Claudia. And you can skip this slide. You can go to the next one too. And I'll pause here for a second. And what we did, we took those insights and the power of the mapping and then applied it to endpoints for respiratory viral illness. So the map that we have, and it's publicly available, you can go and click on it and zoom in to different areas. The map that we have identifies risks to neighborhoods and to communities that are driven by social determinants and that are related to outcomes around a viral respiratory illness. So it's not all outcomes, it's not outcomes related to homicide or related to other events like a disaster of some sort. Is specifically related to respiratory viral illness. So when we look at those disparities, historically, looking at the H1N1 pandemic, what we see is that there's a 3 times higher mortality rate in those highly vulnerable areas compared to the lower areas. That disparity, driven by socioeconomic factors, is something that's been recognized for the last decade, but there's been very little done in that space. It is that space in which we're working and giving insights. So go ahead. So this is a screenshot instead of going live to the website. This is a screenshot of the interactive website. You have the map, and it's a patchwork quilt like you would expect. When you zoom into an area like Metro Detroit, and I live in Michigan, again, you can see as it gets more granular, it's a patchwork quilt all the way down to a very small section, a neighborhood level. This is block level data that is far more granular than zip code. That happens to be taken in LA, where that area, and there's a concentration of homelessness there, is illustrated in the map. That dark purple is very high risk and shows that they're extremely vulnerable. And then neighborhoods right around that, where those populations are not there, are reflected in that lower vulnerability color. So these are actionable insights when it's down to that level of detail, and we show the reasons why they're at risk. This is how we would translate this to action, and the users of this could be anybody from government. The federal government is actually interested in taking the underlying data behind these insights that we've produced and incorporating that into some of the work they're doing. State level government might want to activate resources from the public health department. Local government could activate community services and address any number of things you see here. If there's a hotspot developing in an area, or a city is starting to increase, then getting mobile testing units specifically into those highly vulnerable neighborhoods would be something to do. So to proactively go out and do outreach and engage with them, rather than just continuing the instructions of shelter at home. And in the process, those people that are vulnerable, they're either struggling to get proper nutrition, or they're going out and having to go further, or go into high dense areas where there are long lines in a grocery store, and they're going to contract it. Those are the areas where you might get more food to them, for example. Then you've got another opportunity here around housing situations and housing stability. And these are very real issues where somebody now can't pay their rent, and they're getting evicted, or they're in a hotel and the hotel just shut down, and now they have very few resources on how to manage what happened. So sounds like somebody's not muted there if they can mute. We pull a whole variety of social data. So this shows an illustration of the social types of data we get. We get USDA food access data, census, demographic, and socioeconomic data. It's all publicly available. We don't get down to the person level. We don't get anything that requires consent, like we don't get credit reports. There are third-party aggregators of digital data and one of those we purchase data from to understand at a fairly good level, but not at the personal, but a fairly good level of detail, patterns around digital behavior and activity online. So if somebody's highly digital and you could engage them with an app versus somebody who's not, and they would be somebody who would benefit more from a home health visit or a personal phone call rather than a chat bot. So this informs how to engage people. It informs what their vulnerabilities are and opportunities to support them from the social determinant perspective. These are the sorts of data we use to get down to that granular level of insights that we showed. I'll pause there. Any questions? We learn a lot from the data, and I'll point out just a couple of things. You see at the very top of the list, one of the things we learn is that air quality is a positive determiner, and in fact, it's just coming out. I live in Michigan, and the poor air quality in downriver Detroit with the factories and whatnot may be contributing to the worsening outbreak for COVID in the Detroit area. So that's now news, and it's in fact reflecting what we've shown to be true, is that air quality is a driver for some of these outcomes that is much more weighted than we would have expected. So what we learned from this is the weighting air quality has. We don't use this to create an algorithm. This is something we've learned from having the patient level data or person level data and neighborhood level data and rolling it up and then seeing how these factors play out. The other thing what we learned, and this is more generically from social determinant data in general, the age is you can see there is a pretty significant factor, but gender is not. Gender is down if it's 0.01. It's down near the bottom of that list if you put it in the whole list. It's down there by retail access and much lower than, say, health literacy or social support, which is in the middle of the list around 0.05. So what we learn from the data are sometimes things that are intuitive or that you would expect, than other things that are not intuitive. So what do we do with that? The machine learning takes the core drivers of risk rather than surrogate markers like gender or even race and ethnicity. And we look at the core underlying drivers that are driving some of that risk. Okay. So the problem statements in front of us, the challenges that we face right now with COVID or in the future or in the past several years before COVID or after COVID, the questions are some of the same. How do we address those socioeconomic drivers of risk? How do I deploy my limited resources? How do we best use our resources to get the best value for them, the best outcomes? And it's applying those in more surgical ways to the most vulnerable areas, rather than saying, okay, well, here's a vulnerable area, so now we're going to throw everything at them. If we know one more level of detail, what are the right resources for this vulnerable area? Why are they vulnerable? And then we do something specific about it. It's a more intelligent approach. Go ahead. And at the block level, we also are producing now, and this is new in the last week, we're now producing block group plans. And this will inform strengths and weaknesses within a given neighborhood. and it'll inform specifically some of the community actions and social distancing decisions that could be made. So this can start to inform policy even if it was desired to go to that level of action. Go ahead. And so this is an example. If we take, and this is what we're thinking of going with this, we're working to get COVID positivity testing data. And you combine that to understand hotspots with an area that's socially vulnerable or understanding of the vulnerability, whether it's high or low. And it will inform, given that balance of how active is the COVID disease activity in this area and how vulnerable are they, it could inform very localized decisions around getting back to work or staying home, or back to work with caution. As you can see here, it becomes almost a 2x2 matrix. And instead of a blanket policy that affects an entire state, you can begin to be more granular down to the county level, or even more detailed if you desired. And I think we're to the last. Go ahead, one more slide. I think is the end. And I won't even get into the details on this. What we're just at a high level, what we're also looking at is with patient-specific data, then we can apply those insights and questions to the patient level for our customers, for our health systems, to say, okay, you've got a patient at risk and they're getting into a hotspot area and you need to alert them somehow. And so that's one more level of detail at which we're applying it, not directly related to the map or social determinants. So here's the About Us slide. I already covered that, so thanks for your attention.
Well, so thank you so much. So I hope you're able to stay on the call.
Yes.
We're going to have our next presenter and then do Q&A afterwards. So are you able to hang in there?
You had me for the whole hour, Claudia.
Right.
Okay, great. Okay, so we'll now move on with Dr. Vasquez.
Yeah. You know, I thought, you know, the social determinants of health, you almost come up with a scorecard, which is very valuable. I don't think we have the information, but not the way it needs to be defined. And I totally agree with everything you're doing. So, you know, I look forward to kind of working with you, because I think you're seeing what we all have to see, because, you know, counties a lot of times, because they don't have the data, they often don't want to do certain things in certain areas. And I think this may be what the future holds for managing populations. So I represent G Health Enterprises, so an IPA, a health home, and an accountable care organization. So combined, we manage about 30,000 lives, but not just the different provider groups, but also the healthcare in terms of care coordination. That's what GBON is. We can go to the next slide. So these are the doctors that formed the IPA back in 2008. And it's a lot of the inner city doctors that were dealing with a lot of the community issues. And so it's not something that just happened today. It's been going on, but at least, you know, we were organized back then and really created some interesting models that work for our situation today. Next slide. So I think for us is the doctors do a great job in the box, but what happens when people go outside? We have to have a way to kind of really connect to patients. And that's, as a health home, we were able to kind of have care coordinators. So we have we have 94 navigators, and we manage about 8,000 lives within the health home. And these are individuals that are on Medicaid that have more chronic diseases. So diabetes, hypertension, mental illness, substance abuse. Those are the category of individuals that we manage, and we've had success because of that. And the interesting thing is that they were all trained in the telehealth model. So, you know, we were doing telehealth visits, and also we were using remote monitoring systems that allow us to almost create a virtual visit. We had to back off of those because we didn't have a lot of PPEs, but as soon as we get them, then that's how we're going to really manage the sicker patients that we're kind of encountering. But before this pandemic, we were focused on the social determinants of health, because that's where everything really starts. So we had a gym, we have a kitchen, we have a chef, and we have a pantry, and we do a lot of different things to make sure that the wellness component of it is really strong. And I think the important thing there is, even now when we have this issue, we bought pallets of rice and pallets of beans. we've been able to kind of reshuffle our people. Instead of doing the exercise, you know, there at the locations, they're doing them online. So they have their sessions, they're going through the cook classes, and they're part of the team that got redirected to make sure that we're getting food to people that are in need based on the navigator's report. So we test, we talk to people, they're isolated for this particular reason. We also use the navigators because we have a chief medical officer in value-based. So GBON supports the actual the ACO and the value-based kind of contract, looking for quality metrics, making sure people are doing what they're doing, which is key. And we are, you know, NCQ accredited there. We have a 3-year accreditation, but we did, you know, we've been accredited for 5 years. And I think this piece is real important because these navigators know these individuals. And with COVID-19, the issue you have right now is one person infects 3 people. And what we want to do is use our navigators to infect 3 people that they carry in terms of their load with information. So they've become almost, they're actually the public, oh my goodness, they're actually they're following through on contact tracing. They're actually talking to individuals, finding out who lives in the house, finding out the symptoms, and working with our call system nurses to really help in that arena. And I think containment will help if you instruct people what they need to do. And I think that's the biggest problem. We're telling everyone to stay home, but you've got 4 to 5 generations there. And what do we look for? They don't have thermometers. How do they take the temperature? What do they do in their home? And what should they look for? And when do they need to come to the system? And I think a care coordination arm has helped to really help that. Our call systems, we do about 2,000 calls a day that come in through each of the lines. And they're recorded and scored, and we're kind of making sure that the patients are getting the right information. And I think that's a real crucial piece to the social determinants of health, because we found out what those issues are, and we're trying to deploy things that work. Next slide. One of the things that we saw when we started, so the first year we started with the health home, and this is back in 2013, it took some time because we were allocated patients that weren't part of our network, and it took us 1 year to kind of get sort of our hands around it. But then you could see that during that time, there was a 67% ER reduction that was not only implemented, but sustained year after year. And now we're the lowest, at least in terms of these health homes, our numbers are the lowest in the state. If you look at the inpatient, we had an 80% reduction in inpatient admissions as a result of the work that care coordination and the doctors do and the accountable care organization over the last 6 years. The lowest in our neck of the woods, but at the same time, it's sustained to show you that what you do is sustainable. Next slide. Yeah, next. Oh, yeah. Here, again, we're looking at the cost. Now, this cost is all based on our value-based agreement. So as an ACO, an accountable care organization, we get all the claims data that the insurers has, everything. And so by looking at that, we wanted to see what impact this particular patients in the health home would have in the total system with regards to each of the categories that we look at. And as you can see, GBON as a health home really scored low. I mean, we were low cost when it came to managing the population. So it means you make investments here. They may not always come back initially, but with time, the investments, this is the kind of results you're going to get, which is key in terms of inpatient, ER, primary care. In our situation, primary care went up in utilization, screenings went up, pharmaceuticals came down because we made changes. We made changes on basically 8 drugs, 1 generic for another, and really not losing any impact, and saved $2.4 million. So, it's funny that 1 generic like metformin and another, because one has a little patent and they're both generic, you'll go from a $6 pill to a $340 kind of supply for the month. So it's something that if you're managing the whole area, it helps. Next slide. Yeah, in terms of the state, they looked at our numbers compared to all the other health homes, and only 2 of them were given 5-star based on everything. We were one of them. Next slide. Yeah, so, what I wanted to kind of close up in terms of the agreements and everything that's happening and the social determinants of health and how this COVID-19 is really affecting what we do it goes, when you look at the population that's vulnerable, even that's dying, and you're seeing it in New York City, where you have, 3,700 people that died at home that weren't tested, is that a lot of these individuals in these vulnerable populations have chronic diseases like diabetes, like asthma, like hypertension. And the funny thing is that those diagnoses are all dependent on a system in their body called the RAS system. And that RAS system is what actually grows these receptors on the lung cells. And so these individuals, if you test them for what we call ACE type 2 receptors, they're very high. And that's how the virus comes into the system. So but what we find is the medicines we use for diabetes, hypertension, and these things actually work against those receptors to reduce them. And so you're actually protected if we're actually managing these patients the way we should. So prevention, wellness, key in social determinants of health. Second is really good primary care that lacks in these areas. And I hope that through the work that we're both doing, I think it can really have, it's going to change the way we live now. And the sad part is that these areas that are vulnerable is where you have your first responders. That's where they live. That's where your essential workers work. So if you've got, the bus driver to the ambulance driver to the taxi driver to the nurses to the cleaning staff to all these individuals that you call essential are living in some areas like this. So it's real important that we look at this as it's nationally important because our economies are going to depend on what we do in these areas. That was it. Thank you for having me. Oh, last slide. Yeah, this is and I apologize. So this is the last slide. This is our outcomes for 2 years. For the Accountable Care Organization, that's not just, the IPA. This is including groups that we've worked. Jericho, which is an FQAC, Kaleida, which is a facility a clinic, ECMC, that's a facility clinic. And with these groups, what we are able to achieve with the right IT informatics and the care coordination, we saw a reduction in ER by 27%. Reduction in inpatient. This is on 24,000 lives, totally separate than what I was telling you. There was a reduction of 12% there and an increase in generic brand by 12%, which there was a cost saving. But when you look at the quality measures that are real important, you saw an increase of 16% on diabetic care, 11% on colorectal screening, and that diabetic care meant retinal exams that we were doing. And then hemoglobin A1C, an increase testing for it, and breast exams increased from 5%. So all these numbers, for the fact that, it is working and the savings go hand in hand. We saved about $748,000 in ER costs. We also, on the inpatient side, $323,000 and $1.9 million on the pharmaceutical over those 2 years.
Dr. V, thank you so much. And always a pleasure. When you work with, we've had the pleasure of them being a client of ours. And I always learn from good clients. You learn from not so good clients as well. One of the things you always taught me was analytics do not matter if you don't have an intervention, or signals don't matter if there's not an intervention to play. We asked you to be brief, so I think you missed something that maybe you could share on how you're using the data about people's different situations. They may not even know really what a health home is, and how you're using that social determinant data to know what other actions are required besides the clinical care that is so important to stitching together what you accomplish. And even Dr. Fromfelter mentioned the interventions. They do the analytics that can lead to interventions. You do your own, as well as make them actionable. Can you just maybe share a couple of stories or describe how you do that a little bit?
Yeah, we could talk about the COVID-19. What we did when this whole started, we flipped totally to telehealth in the medical practices and the care coordination, but we looked at the data. And with the data, we actually put some chronic diseases that were there. So anybody that was COPD, diabetic, hypertension, over the age of 50, we pulled that data out and actually used the robocall with the message. So they would understand the symptoms, what to look for. And if they had questions, they were directed to our nurse call center. When they called into the nurse call center and they had those symptoms, then we use that as a way to kind of set up our testing for the individuals, the right individuals, the ones that are high risk with fevers, cough, shortness of breath, or chest pain. And that kind of gave us a better perspective of not only deciding who to test, but then using the health home individuals, who to contact trace. And I think that's real important, because once you have that, we learn more about the pathophysiology of how it comes into the body, and what kind of sort of treatment patterns have to be used, even if you get to the point of smart quarantine. And I think it helped us because of having the data, knowing to call, knowing those relationships, knowing that they're trusted. Some communities are still not trusted of hospitals and counties, and this became a really easier platform just because the data is available. And within the ACO, we get our claims data, so we would know who the superutilizers are, where they're going, what drugs they're getting, what are they being hospitalized for, are they, what ancillary services are they using, and professional services, are they actually going to primary care, are they getting the quality measures? And the more information you have with what you do, it becomes real important to kind of manage a population that requires a little bit more skill set than just come into the office and go home. I hope that was helpful.
A question about, which will also help you answer that even further. What is a health home? So the health home
yeah,
being,
the Affordable Care Act was put together, and what happened in 2013, New York State allocated monies to what they're called health homes, and what it is you have to have a care coordination kind of model there, and they basically assign people to you that they find, based on the data, are costly. They're going to the ER. They might have mental issues that they're not getting treated, or they have diabetes, they've had amputations. These are the individuals that are having a hard time. So they found that if you attach them to someone that can guide them through the health system and really, did other things besides that, they wanted to see the value of it. And what we found was that, we began by training the navigators in a case management that was NCQ accredited, but we took people, some of them were on Medicaid, some of them were the patients we're treating, that we put them through a training system of 2 to 3 weeks, and now they have a job sustainable. We've changed lives that way, but it's also, we've taught the community what's important for them. Especially if there's so many, if there's a lot of testing. Oops, I'm sorry, I got a quick question. If there's if there's a lot of testing, what needs to happen? So we would know if people weren't getting eye exams, we developed models to have the navigators go out and the testing go out to the patient, or make it mobile. So they would come in and the tests were being done in specific sections of the office. Mammograms, tied into mammograms, people that didn't have mammograms, we got them scheduled, we cross-schedule into the system, and all the numbers started going up. And I think by finding out patients that had issues with blood pressure, hypertension, we assigned them to the wellness section. A lot of individuals lost anywhere from 40 to 60 pounds. They saw the impact of blood pressure and diabetes on that. And some of these individuals I didn't even recognize because, they just lost so much weight. I was worried that they were sick, but
thank you
those
very
are
much.
the interventions, that
I want to get to a question to Dr. Felter, but first, there was a question about, is a health home the PCMH model? No, they're different. So PCMH is through all different payer mixes and all different socioeconomic statuses. It's the process and the discipline to quarterback care across all the specialists. The health home in New York, at least, is for folks that have multiple comorbidities, usually do have or may have behavioral health issues or substance abuse issues, and many challenges with the social determinants of health. So a health home provides the care coordination and connects patients that are having clinical challenges with all the social agencies that need help. And Dr. V is probably being a little modest, but his organization does an amazing job of understanding what their patients' social needs are and uses that information and those services to address those aspects of care, and did a lot of that during the COVID experience as well. So, Dr. Fraunfelter, how would you feel if all of your projects that were able to get access to the social determinant data had an operational arm that could actually do something with that, right? An intervention based on that. Would that make some of your projects even more successful, do you think?
Oh, absolutely. In fact, I mean, this is just knowledge in a closet if it isn't operationalized. So we provide in its typical form. This is clinical decision support that clinicians use. I'll give you one example, and this is one of our customers in New York City. Actually, we provide insights along with the lines of what Dr. Vasquez is doing, prevent avoidable admissions, prevent avoidable ED visits, and it's very impressive the results that you got. So we'll identify patient-specific risk interventions. One of those was on a patient that is diabetic, and we recommended evaluating their diet. Now, we didn't know, but the case manager who was doing the home visit on this patient knew that he was a very famous chef in New York City. And she said, I hate to ask this, but, can we talk about how your diet is? And he said, what diet? And he opened up his cupboard, and it was all processed foods. And he says, I don't have time to cook at home. I'm busy working 12 and 15 hours a day. And so there is nothing of value about knowing something if it isn't operationalized. And we've got to make those connections to go from having so there's a chain of connections here I'll make. We know that social determinants matter. Okay, that's great. We've learned that really significantly over the last several years. Which one of those matter for which patients becomes a more important question. Otherwise, we're just throwing blanket solutions at a community and hope that a rising tide floats all boats.
Yeah. And, let me tell you, so the way I see you functioning, which is key, is right now we have Z codes, and we're using a lot of Z codes to kind of address the homeless and everything else that happens. But the one thing that we don't have is a social determinants of health index that will help also, because right now we use acuities. If you're a hypertension and you have these things, it's acuity, and the higher the acuity, they know you're going to need more resources for that individual based on that. But there's no attachment to the social determinants of health piece. So an index that would actually not only take that acuity, but be calculated into that acuity. So that listen, this person, because they're homeless, because they don't have transportation, X, Y, and Z, will require more resources, and it will help us redirect the resources to the individuals that need it. But there is no social determinants of health index that needs to be tied in. And looking at your data point, I see this as a perfect index to kind of add as a billing. And since we're an accountable care organization, we work with the insurers, we can look at how to tie that in to the premium and then push it up and basically fight, whether it's CMS or the payers, how to really make that number a little more reasonable, because, physicians are just seeing patients and they don't see that all these things impact what you do.
That's right.
Go ahead.
Well, I was going to add, one of the fallacies that we've seen as social determinants has become really important, a buzzword in the last couple of years, is to know something about a patient. We translate that to equaling risk. So if we know that a patient, for example, doesn't have transportation, that's not the same impediment or barrier to healthcare for every person equally. So to know which patients is that for a barrier in the absence of their own transportation, is that actually becoming a barrier, is still the mysterious part of this. And this is what the AI that we apply helps to solve, is which of those things actually become risk factors rather than just facts about a patient. To Dr. Vasquez's point, we need to know their total risk, and then you can get them engaged in very, very valuable ways. You get even more precise when you know which of those risk factors are actually driving the risk for an admission or for a deterioration in their health.
Right. And so could you imagine, Dr. V, necessity is the mother of invention. You guys do amazing things with not a huge budget, and you use the technology incredibly. If you had additional data and insight that you could help better understand your neighborhood is really what it is. And you understand it from the street level very well. But the proposition that Dr. Fraunfelter has is that JDON helps large and sprawling urban cities as well as smaller ones to do that. is that something that you think would help you provide a little more insight and be able to help you
Yeah.
do things?
No, absolutely. I think, we're data hoggers, so we're always trying to Hadoop as much data as we can because it's all valuable. It comes in, you start looking at it, and when you stitch it up together, you make the invisible visible, and then you go, wow, I didn't even see this. But yeah, because we the transportation we provide for free. We do a lot of things that we did for free because it impacts everything else that we do. So I agree. I agree. Having at least a measure of that is quite important. I mean, so we have 3 apps. You'll meet the only doctor that created his 3 apps, but our apps are pretty useful. I mean, even during this time, I think we have about like each app is downloaded like 1,400 times, but it's a good push technology. So people are getting the right information. We have a COVID-19 screener. So they fill it out, and then they end up, that goes directly to the nurses and people that need to be called. Everybody gets called, but who needs to be tested? That works out really well. And these are the types of tools that are going to be important. In that app, they'll know how to call for what. There's a health encyclopedia, all free, but having that kind of data, your data can blend in to figure out how we make that app smarter. So, by the way, we understand X, Y, and Z, and making sure that when people are checking in, because, people do have phones and not everybody uses them effectively, but they can be taught on how to use them to get this information that's valuable.
And Dr. Fraunfelter, is anybody using your SDOH maps for COVID? And in particular, it seems like New York City and some other metropolitan areas would benefit. Anybody using that yet?
Well, we've had it's hard to say who's using it. We've had over 2 million hits on the website in the last few weeks. So we're getting some feedback. We're getting requests from several universities, Johns Hopkins, UCLA. We're getting into data use agreements with them. We have calls with a couple of states I don't want to name, and I did mention we've actually been the feds have reached out to us in the last couple of days. We have several calls going on this week at the federal level. So I can't speak specifically to New York City or which governments are taking action on them, but there is quite a buzz getting stirred that, and so we're responding to that. And I showed in some of the slides how it could be applied, both reactively in the COVID crisis. How do we better manage patients or look out for vulnerable neighborhoods now? And then also prospectively, when we think about getting back to work and who are the vulnerable neighborhoods that we need to really protect as we're relaxing some of those strict stay-at-home restrictions.
Okay.
And I'm sorry.
Question from Rani Abelmugan. Dr. Fraunfelter, has JVM worked with employer health plans to apply member-level SDOH to further the way they could tailor their benefits or make sure there's better access to care?
Yeah, it's a great question. We've had a spectrum of types of engagements. Some are with health systems to provide care for their patients. That's typical. We've had some with payers directly that are customers, but this is one that's really interesting. There's a huge opportunity there, and we've had some of our health systems very interested in it. It's been health systems going for benefits to their employees. I'll give you one illustration of that. This is in Alabama Baptist Health down in Alabama, and they have an employee health plan with about 4,000 total enrollees in it. And we identified the top 100 patients at risk in the next year for utilization. And based on that, they had basically 2 half-time case managers, so a total of 1 FTE, working with those patients and targeting them. And we also identified not just the risk, but we also identified the interventions that would be most impactful on those patients to help to reduce their individual risk in an individual way. So the answer to your question is a strong yes. We help to identify not only the patients at risk, but link them to the right interventions. And that's based upon, we work during an implementation to understand what are the interventions you offer. So we're not just doing them based upon all of our customer base experience, but what do you actually do? And then we take those interventions as part of the machine learning to say, okay, which intervention is going to be most effective here?
So I know that in Buffalo and in Rochester, we have these things called PPSs, Performing Provider Systems, that are part of the district program. It would be valuable if they could sort of have that take on what are all the different social services needs and make a sum of it, so they could do like the capacity planning for the community-based organizations, because we have so many organizations, but it's hard to get them aligned. I know, Dr. V, you were working with those organizations at least a little bit. Want to share a little bit about how you're helping out the district group and how you hope they'll be moving in your direction in terms of measures?
Yeah, the district group, the good data. The problem is the salient data was always behind. I mean, so you're looking at almost a 4-year look back of what the files they got. All the hospitals are trying to get like healthy intent, different population tools, but they were never able to get them to work, which was tough because, and when we started to dissect the data out, the data was, the data is only as good as the data that went in. So that was a little bit tricky. For us, the advantage was the tie into the insurance companies and getting that total data. I think that gives you a better perspective. The state has it. When we're looking at the social determinants of health, they have this website that does vulnerability indexes, and they were all set up. And I think that would blend in well with what you're doing. It's all based on zip codes, based on the needs. So they would use that platform. God forbid there was a major disaster area. And so we've created infrastructure for this. And I think the what we're just looking at also would complement what we're trying to do really well. But we do have a lot of data out there. It's just not being, and this thing narrows it down by zip code. What are the needs? What are the areas in the map that are red, yellow, and green? And I think, but I agree with you. Looking at that stuff is going to be real important in the future. But we in the district we improved things, but we didn't get to the level we needed to because of not having the right population tool fully integrated.
Right. Any other questions from the group? If not, it sounds like the New York State Vulnerability Index might be something that if it's not as good as it could or should be, it might be something that could be made a little better with the JVON tool.
Mm-hmm.
Okay, the communities with higher prevalence that might be prioritized for a longer stay at home are likely the communities with the most SDOH risk factors and the least ability to stay home from a financial standpoint. How would that be addressed?
Well, well, I'll take my shot at it. But we're trying, so test, trace, and smart quarantine. And this is where we're going to have to do something. So, and this is all hypothetical and based on what I'm seeing. In terms of those receptors in the lungs, those are the ones we're identifying because those are the ones that die. We have the same receptor type as in the nose. So if the virus is coming in through the nose, the symptoms are different. People are having more fatigue, tired, and sort of loss of taste and smell. Those, I believe, are going to be our carriers. So if you're a carrier, I don't think that 14-day line works. You're more in the 21 to 30 days. So being able to start to, this is also going to come down to almost how we manage hepatitis B. That we have, we know who are positive, where the window is, who are sort of recovered because of the IgG, and when the vaccine comes out, who has the marker for the vaccine. But at the end, who our carriers are. And if we don't do a good enough job there, then we're going to run into problems. The good thing is we have drugs in hepatitis B and hepatitis C that address the carriers. So that's going to take a little bit of time. Once the blood tests come out with the right markers and we follow this arena, we'll know who falls into what category so we can release people back to work. And we've been talking to some of the governor's people about it because I think it's real important, not just have a test, but have the right test for what we're trying to do.
Sure.
And you take some of those people and now they've got to stay home longer as they see that. I read the question here, and those are the ones most vulnerable. They need to stay home longer, and they're the ones least able to do so. And this is where
Uh-oh, we lost the sound, or is it just me?
Yeah, no, I think, yeah, we lost the sound. I'm sorry. I was like, oops, I must have disconnected.
Can you hear me?
Now
Yeah.
we can.
Yeah, now we can. Thank you.
Ah, okay. Uh-oh. Shows my connection is unstable. Can you hear me still?
Yes.
Yes, yes.
Okay. Well, let's hope I stay stable here. So you take those patients that are vulnerable, and they are the ones that need to stay at home longer in a certain area, let's say because of prolonged incidence hotspot, and they're the ones least able to do so. This is where community services, public health departments, even state level health departments can surgically insert resources in those neighborhoods. About a month ago, when we were looking at rolling out the map, and early on, I went to the Michigan, because I live in Michigan, the Department of Public Health there, and they have, a page of different sorts of resources that even support housing and support food access,
Yes,
etc. And so it's connecting those resources that are there in many
correct.
cases with the neighborhood level. And so we go all the way down to that neighborhood level. You could never do that for a zip code, but for example, within LA County, there are 8,000 block level sets of people in one county. And
Yep.
which of those blocks really need the support is the level of detail we need to get to, because we don't have the infinite resources that we wish we had.
Correct. And what we do with that is, so as part of the proposal that I actually gave New York State, is the testing piece before that actually involved the churches. So we have 15 churches, zip code around where we feel the problems are. And then we have a connection to the churches they chase the list. And people that don't have primary care, how to get them, make sure the food assessment, the medicine assessments are taking place. But then we also tie into the CBOs and that do what you're talking about. So, who's providing food here, who's providing whatever housing entities are coming up. And yes, creating a medical neighborhood model, which is what we've been trying to do up here. And I think once you have that, then you know how to manage, but also having the dollars to put some of these individuals into a hotel quarantine model, having telehealth, managing them, making sure if they get worse, directing them directly to the ICU. But if they don't get worse, how do we get them stable to go back? Or if they're these carriers, how do we spend a little more time with those carriers to really address the issue we have?
Yeah, there's an interesting aspect. So we're actually working with Monroe County here in Rochester as well. So healthcare workers have one perspective of how to manage and monitor and keep people safe, whether they're COVID positive or suspected. It's different when you're public health and you're trying to contain the virus. And I think it's almost like providers and payers now collaborate in ways that we're all getting used to. Healthcare and public health are now going to have to learn how to collaborate with each other in ways that they haven't in the past. Either of you comment about how you see that playing out?
Well, I think it's going to be important. The payers understand that the only way you're going to address these types of cost issues is you got to get involved with the players that cost, the doctors, their pen, the things that they do. And if you get the doctors more on the same page, you're going to have a better sort of outcome. And also give those doctors access to the data so that they know. So if this patient comes in, you get a beep, yep, this person has X, Y, and Z. By the way, you have all these chronic diseases that are out there that you're not including within your plan. That helps the doctor to decide, because they're going to mental illness. They may have schizophrenia, bipolar. I don't know what meds are being done there. They may be substance abuse. They're getting medications there. I don't know what they're getting there. And then, they come in for pain and they have a fractured ankle and you got to give them stronger for pain. Now these drugs all kind of interact and can really affect the outcome. So that becomes real important in what you're saying. And payers are looking to give the doctors sort of control on the data and say, okay, you guys manage these people. And I think that's the vision. Value-based, like we talked about, will be what happens in the future.
Yeah, I think that's spot on. I think there's a growing desire to collaborate. I still see technology needs to be more enabling to allow people to share, the providers sharing information or getting information from payers in real time. So there's still some barriers around technology enabling sharing, and also some policies, regulatory aspects which actually have improved with the result of the COVID crisis. Some of those barriers, for example, around telehealth have all come down. So I think there's hope.
Great. I want to thank you both very much. And
But, oh, hang on a second, Al. I think we've got a question from Adam. Adam, do you want to go ahead and ask your question, or would you either speaking up or by chat?
I'll just speak up. Can you hear me okay?
Yes.
Yes.
It was kind of more a comment than a question, though it could be both. I mean, essentially from what you just said, other parts of the world have actually been doing aspects of social determinants of health for a long time. And when you raise specifically the issue about how does public health communicate with healthcare organizations or providers, one of the ways they've done it is through needs assessment. So just really asking, there's kind of an evolving discipline of needs assessment, which is how you do the piece which is complicated, which is how you then begin to think about how do you shift resources between relative priorities. So that was the comment, and whether it raises any thoughts from yourselves.
No, so on our side, when the district started in our neck of the woods, we kind of got into we had a disagreement as to what needed to happen. So we actually went to the churches, and then we had some CBOs, and we brought some professional players to start to do some analysis, and created a needs analysis based on the needs in the community. And then that was a seed that was introduced into the district. But I agree with you. I think that we have the needs information in a lot of these entities, and I think right now we just have to make them actionable. And I think data that was presented today tells you we have the data. We just have to do something with it, not just talk about it.
Yeah, I would agree with that wholeheartedly. Thank you, Dr. Vasquez. I'm so impressed with the work you're doing there. I just wanted to say that. But what we do have the data, and what we're showing with our insights is that they are both actionable and far faster and more efficient than the manual, hard, good work of doing manual risk assessments. So those are probably still valuable to do on pinpointed patients when we say the risk is high. But to do those in a blanket approach isn't efficient. It's not fast enough.
yeah, seeing the best of both of you guys, a lot of communities would be very well served to have that data and have the group that could operationalize it. We would be able to better serve our communities. I want to thank you both very much for adding your perspectives, and a lot of people will get some insight and hopefully get them to move in that direction. We are looking for other examples of best practices for our future meetings or other topics. Claudia, do you have anything you'd like to close?
No, I'll reach out to the participants today. But again, I really want to thank both Dr. Fraunfelter and Dr. Vasquez. Thank you so much. That was absolutely really fascinating. Thank you for your time. I know your time is really stretched during this pandemic. So really appreciate it, and want to thank the work group participants and Al for leading the discussion. So we will check back with you. We are having another work group meeting on May 20, and we'll be reaching out to you regarding the topic and the presentation. So again, thank you all. Have a good afternoon.
Thank you.
Thank you.